Alright, so this is a video on my approach to total knee replacements and how things might be a little bit different than the traditional model. First thing I want to do with my patients when I see them is obviously watch the way that they get up out of the chair and they're walking, and see how they are tolerating weight bearing over that leg. We really want to stress to them that they need to get on the heel and get the hip to come out to the side. If you think about it, if I have full hip adduction, weight bearing on this side, I will probably get better from the extension. I get the screw home mechanism to kick in. I get knee extension. I'd rather have them do this and feel like they're getting something out of it than fight it either on their back or on their stomach. I call that standing or weight bearing hip adduction on that side. Now, if they struggle with it, I may put them over here and give them something to really work on and get into. Get them close to a wall, so they'll bump lightly here. So we call it the bump, because your goal is to try and get there softly with control, not banging into the wall on this side. Again, give them strategy. Tell them they can work a couple inches from the side here. If they're getting a little better at it, more comfortable, they can work a little further. And they've got to work on a weight shift off that side as well, so they can control that. Now, for most guys, you're going to struggle a little bit because you don't have a lot of hip flexibility or understanding how to get out there. For the ladies, it's good for stability. You get a chance to work on control. And if you think about it, if I've had a knee that's been problematic for a long time, I would probably be walking with that kind of a gait pattern, right? I don't want to be on that side. So relatively speaking, I'm going to abduct that hip to get off that side. Plus I'll gap my medial compartment when I do that, so I might get a little bit of relief pre-surgically. Now, post-surgically, you got to get on that side to be able to get out there again, right? So once we finish doing this stuff, and people feel a little more confident in walking, I may actually have them walk in that fashion, so I exaggerate that. I call it the runway pattern when they're walking, so they're forcing the hips to come out. And again, full knee extension, kind of getting the combination of things to put themselves back in place here for normal knee. Now, early on, I know it might be hard for patients to do some of the stretching that I'm going to show you here, but I'm going to try and emphasize three-dimensional stretching for patients, especially after total knee replacements. Really, I'm a big believer that we don't just stick to a straightforward one direction stretch because that's how we're taught and we have to be able to think outside the box. So we're going to give them a calf stretch, and granted they may be sore from the swelling and from surgery itself, but let's try and get the calf muscle stretched out. We're going to do a typical runner stretch against the wall, which I think is the best way to work this. I'm going to put them in a position where actually line the toes up, both parallel and straight forward. Let's keep that arch supported. As we're stretching, I want to make sure we're doing a little bit of three-dimensional side-to-side steps. So it's going to look like this. Come on, stretch. A little shifting. Get the entire calf to roll through that range. So we get a little bit more of the entire calf stretched out versus just one strength. Very rarely, if at all, we find me taking my patients who've had total knee replacements and putting them on the mat for any exercises. We exist on our feet. We walk, we weight bear. Very seldom we really train for an activity on the bed. I really think we need to rethink the way that we approach total knee replacements from that standpoint. I know we all learn to do the exercises on the mat, but think about it. If I force somebody who's had a history of knee pain, who probably is dealing with a little bit of back issues as well, on their back, and make them do a straight leg raise, am I really helping their back? I'm overloading the hip flexors. Probably going to result in they're probably going to have some problems down the road by putting too much torque on their spine. So I would much rather put them in a place where they can work standing. We can give more muscles to work. We can get their proprioceptors to kick in. They can balance out, and they don't have to try and add something to that program later. So one of my favorite things to do, if I want to strengthen my right hip abductors and I work on stability throughout the leg, I'll put them with the ball into the hip on the other side. And I force them to get under the ball a little bit more on the side so that this hip abductor has to work to push me that way. I'd much rather have them do this where they feel stable and they got something to lean against. And they're probably not going to have the same pain level as they would if they were laying on their side trying to do hip abduction. Even supine hip abduction, sliding the leg out, really doesn't hold a candle to this. This gets them in a place where they can push with a little bit of force or a lot of force. So this is my favorite way to get hip abduction working. You can also work on hip extension. If you think about it, put them in this position, force them to get the heel down, have them do a little pushing. Okay? So right hip extension helps me do this. I could put them this way as well, put them on their backs. One thing I don't like that people often are shown as an exercise is wall squats. And I know it works your quads, right? Functionally speaking, do we ever really work your quads without your hips? I'm not seeing that. So I would much rather they work on full weight bearing, not against the wall. If they're going to use the wall, maybe they do this. They reach in and touch the wall. So they've got to work on their hip extension eccentrically while they're working their quads eccentrically. Right? And that just carries over to having to do all their functional tasks without their hands. So sitting, standing, I'm going to watch for excellent alignment, making sure they maintain the patella at the top of their foot. But I'm also going to say I need them to emphasize hip flexion during rising and sitting. So one of the easiest ways to get them working is to say to them, every time you get out of your chair at home, good mechanics. Every time you go to sit down, no hands. All right? If they're close and they're safe and they use full knee flexion, I don't ever want them sitting out here because they were told in the hospital, make sure that knee's out in front of you. Get underneath you, use it. Right? Use it or lose it. But I want them to drop down smoothly. Right? Worst case scenario, drop a little bit. Some of them do that anyway. Now they get a reason to do it at times. So emphasize good body mechanics at all times. That becomes their number one exercise. That then becomes the exercise they carry with them for a lifetime. You don't have to think about setting more time aside for it later. They can just simply do it and maintain their strength. So we're going to talk about trying to get someone who's just a few weeks post-surgical to get their quads to kick in. And we're used to having them on the table doing the quad sets and straight leg raises. We're trying to put them in standing and just thinking new ways through how to get those quads to work. I really like an exercise where they stand and they work on what we call a goose step march. So I'm doing an active internal knee extension here, but I'm trying to balance on my opposite leg as I do that. Now, obviously, most people aren't going to be able to do that right off the bat, so I might give them a little bit of something to work on, occasionally holding on. But I want to emphasize locking my quads in with the leg I'm raising and balancing on the other one. So when I ask my patients which leg's working, there's no wrong answer here. They're working their quads on the side they lift, short little lift. They're dynamically holding everything else on the opposite side. So if they're not comfortable lifting the leg up, well, don't let them lift that leg for them. Make them stand on it. If they can, do a quad set on the other side. Gradually, like to see them do it evenly on both sides, so they're also alternating. Quicker on one side, doing a quad set, quicker on the other side, doing a quad set. And you work on control. And we're going to emphasize balance awareness as well. So if I can get them thinking, I've got to start doing more of this, they start becoming more comfortable. Another thought for an exercise progression here. Ultimately, we're trying to get their quads to work so they can lower themselves down the stairs, they can sit down effectively, they can reach down and do things alone. So we're working on eccentric quadricep strength. One of my favorite ways to get them doing that is once they can be a little bit more comfortable standing and progressing over one foot, I want them doing things where they have to trust that that leg can hold them when they do a little bit of reaching with the other foot. Now this may take several weeks for them to get to, but that's our goal early on, is let's get this control back. You're probably familiar with a lot of things that Gary Gray has done. He likes to emphasize doing some posterior balance reaching, right? We can do some lateral balance reach. And again, you get to watch alignment, instruct the patient that you can keep that position near the top of the foot. I like it because they have to work on the hip control at the same time they're working on quadricep contraction. But don't forget there's anterior balance reach, which simulates them stepping downstairs, right? And when they say, well, when am I going to be ready to start walking down the stairs, or when can I do that better, you can give them something to work on. Well, as you start progressing down, you see that control come back, you'll feel more comfortable going down the stairs. Areas we don't tend to emphasize as much as therapists, they need to be able to develop a rotational sense of control as well. So don't forget that part of the balance reach progression is backwards, sideways, forwards, right? But in rotation. Now think about what VMO is going to do here if I pull somebody out into a lateral balance reach, right? If I emphasize my trunk going this way and my knee wants to collapse that way, VMO is going to pull me back to a better position. So I want to emphasize things where I'm going to throw their upper body off balance, maybe the other way. I might throw them this way, right? Posterior balance reach, but they're reaching laterally. Okay, try it sometime. It's a good workout. I might put them in a position where they have to balance reach and really emphasize reaching forward. I might put them in a position of trunk rotation, really making them work on that quad control coming down. So consider that progression as you see your patients go from some of the simpler exercises to some that are going to get them back. All right, let's talk about some other ways they can get their quads and their leg working that don't include laying down, doing leg raises or leg slides, things like that. Emphasizing use of TheraBand is actually kind of an effective way to go at this. Think about it. Let's connect the upper and lower body together here. Gary Gray would tell you that one of the most underutilized or underemphasized areas in knee rehab is your abdominals. Think about that for a while. Let that settle in here. If I take TheraBand, hook it around about waist level, then I get a chance to emphasize standing on my affected leg, my right leg, maybe balancing a little bit on my other side, but working on pulling my arms back. What am I doing in my quads? I get a chance to work on a quad set, and I'm pushing forward, relatively speaking, against the floor with my foot. So I can work on quad control. If I emphasize a little bit of rotation with this to one side or the other, now I'm getting my trunk and my quads to work together in a slightly different plane. So it gives somebody a chance to work on quads without just doing quad sets or just doing straight leg raises. Balance is coming in, trunk is coming in, the patient has a chance to work out in general. They get a better sense for it. Letting their body help them with balance instead of just making the foot do all the work from down below. So I like that. If you think about changing directions then, you can really emphasize getting some quad control if I pull straight across. And again, emphasizing good body mechanics, not letting them fall to a valgus knee position. So here,